Okay, I think Shilpa madam, we've gone live, so
Yes.
you can start the session now.
Yeah. We are not able to see you. Yeah, now we
Yeah.
can. Yeah. So, hi everyone. This is the second session on reproductive immunology topic, and I think this is one of the most important part of the whole series that we will be doing. This is regarding the investigations. So, rather than just giving blanket treatment, assuming that there could be some problem immunologically, I think it makes a good scientific sense to actually evaluate, and how much to evaluate, what to evaluate would be the gist of this class today. So we will finish this probably within 15 to 17 minutes, as we have kept our sessions for those many minutes. Over to you, sir. You can take over.
Okay, so I will start with the screen sharing. Uh, just a minute. Yeah. Uh, can you uh, can you guys see the screen?
No.
Okay.
Yeah, now we can.
Now you can see the screen, right?
Yes, yes.
Fine. Okay. So here we are just going to speak for the next 10 minutes. Okay, on basically investigations in reproductive immunology. All right. So I'm going to just divide them very simply, because we have studied the last session. So people who have not gone through the last session, please go through it. Okay. So please remember that most of the investigations which you require are going to be costly, and they may or may not add value. Okay. That is important. So we will still start with the list of investigations which people like to investigate. Okay. I will write them down one by one. One is blood group. Okay. For male partner, female partner, both. Second is karyotyping, male and female. So basically, you want to evaluate this reproductive immunology in these conditions only. All right. When there are more than 2 consecutive IVF failures with excellent morphology of blastocyst, okay, or PGTA proven euploid embryos, okay. Simultaneously, if there are more than 2 episodes of recurrent pregnancy losses which have occurred in the past, okay, this is your primary criteria. Though the criteria is still 3, that you should have more than 3 abortions, more than 3 failures, for a broad perspective and in local understanding, this is to be done in 2. Okay, so just keep this in mind. This is your primary criteria to do this. Okay, so this is your one, blood group. Second is karyotyping. From third onwards, it is important: antiphospholipid antibodies. Fourth, anticardiolipin antibodies. Let me just add, along with anticardiolipin antibodies, anti-beta to glycoprotein. Okay, let me just add this thing. Fifth, hysteroscopy. Okay, so I'm going to keep on listing indications. Okay, sixth, sperm DNA fragmentation index and morphology. Seventh, AMH of female partner. Very important investigation. Eighth investigation, protein C, protein S, factor V mutations. 9, product of conception karyotyping. 10, 3D ultrasound of the pelvis. All right. Now, I have missed out one or two investigations, but I have written down the top 10. The reason why I have written down the top 10 is because if you were to do all of this, okay, then the approximate the patient will end up spending is going to be only 65,000 rupees. Okay. In that much, you must understand that for majority of them, the treatment is something which is very, very expensive, which is ecosprin, which is going to cost 4 rupees. Okay. So now you are supposed to decide that in order to put a patient on prophylactic ecosprin, do you want to end up spending 65,000 rupees of the patient to do an investigation or not? All right. That is something which you have to keep in mind very, very importantly. There is just one thing which I want to write. It is a special circumstance where we will do it, and that is CDC cross match. Okay. CDC cross matching, SOS, HLA typing. I will just speak about that in a little while. All right. So blood group. Let me just start off with the blood group. What you should understand, it has got no role. All right, irrespective of the blood group, unless and until there is RH isoimmunization, anti-D has not been given. It is a reproductive immunology problem. But remember, this reproductive immunology problem is then going to be decided by indirect Coombs test, the titers which come out of that, and you are going to require some amount of fetal therapy. So this is very, 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 very simple. You need not worry about this. Okay. So the first thing is sorted. Blood group ka importance you understand in 1 minute. All right. Now, second, karyotyping. Okay. Do we do the standard karyotyping or do we do whole gene exome sequencing? Okay. Do we do a whole exome sequencing or do we do a standard karyotyping? Just the routine. Okay. So if in case you have to do the routine karyotyping, remember for a couple, it will cost you around 6,500 to 8,000 rupees, and whole genome sequencing for the couple will cost you approximately 55 to 70,000 rupees. Okay. This is done on NGS platforms. All right. Now, what is the importance of doing this? This is going to be otherwise indicated in couples who have more than 2 IVF failures, more than 2 recurrent pregnancy losses. But if this is normal, if the routine is normal and still, okay, there is a history of having either an anomaly, there is a history of having consanguineous marriage, there is a history of having a storage disorder. In all these situations, you can ask the patient to also do whole gene exome sequencing. Only remember one thing, this is a very expensive test. This is a genetic problem. And if you have a genetic problem, majority of your immune therapies won't be working in this case. Okay, so please remember this. Whenever you do a karyotyping, thinking it may affect the immunology, you can't really change the karyotype of the couple. What you can do is you can either change the gametes or you can counsel the couple accordingly. So keep this in mind. This may not be a first line investigation when solely immunology is the problem as far as the patient is concerned. So please just keep that in mind very nicely. APLA. We all love doing APLA. Okay. Our love for APLA is eternal. We all love doing APLA testing. Okay. The thing about APLA testing, which you should understand, is APLA, anticardiolipin, anti-beta 2 glycoprotein, all these tests you do, these are all brothers. Okay. These are all tests which are correlating to each other. All of them are indicating of an altered coagulation profile. This is all that it indicates. Because they are all causing some or the other form of altered coagulation profile. Remember, ultimately the treatment for these guys is to give, which I have mentioned, that is to give ecosprin plus low molecular weight heparin, and you need to counsel the patient accordingly. But if you have diagnosed APLA, diagnosed anticardiolipin beta 2 glycoprotein, not so many people do. But if you have diagnosed APLA, diagnosed anticardiolipin antibodies which are present in your system, then your treatment is very straightforward. You don't require any other form of immune therapies to help you. All right. So that is a very, very important take home point. So for people who like to do this, please remember that, okay, this is what it is going to help you out in. All right. So I will be deleting this. One thing which you should not be doing when you do all these tests, there are the love for doing torch test is so much that people, their battery switches off the minute they tie of thinking of writing down torch test. Remember, whenever you hear the word torch, you should have a tube light in your mind. Okay, the torch test has got no role, limited role, at its best, okay, when it comes to reproductive immunology. All right, I know there are many people who love writing these tablets. One is Sujat, second is Torchnil, and they think that whenever you give these tablets, it is going to alter the immunology and patient will have no further abortions. Remember, the role of all these types of tablets is really like saying that, you know, you are giving diagnose for endometriosis. It is as bad. Okay, so please keep that in mind. Sperm DNA fragmentation and morphology. Histoscopy I'll discuss little later. Okay, this I'll discuss little later. Sperm DNA fragmentation and morphology is very important. But remember, this cannot affect the reproductive immunology. So even if you do this and the patient has had two IVF failures, patient and has two recurrent pregnancy losses in the past, if the male partner's DNA fragmentation index is more than 25%, you can treat them and you can do IVF in a better manner to form better embryos for this patient. But immunological alteration with sperm DNA fragmentation is going to be very limited. Okay. Same thing is with AMH. Low AMH has a higher risk of developing the same history, two IVF failures and two recurrent pregnancy losses, but no great role in changing the immunology. All right. Now, protein C, protein S, factor 5, these are expensive investigations. All this again are indicative of coagulopathies. Okay, please remember, when you have altered ratios of protein C and protein S, your treatment becomes to give low molecular weight heparin. You can't really add an immunological outcome to this to change it. Okay, this is a diagnosed cause of having problems as far as pregnancy losses and implantation failures are concerned. They have got very limited role as far as immunology is concerned. So see, one by one, I'm just taking out everything. Correct? Point. Product of conception karyotyping. What is important about POC karyotyping is that you can have only two things. The POC, that is a product of conception, is abnormal, or the product of conception is normal. If the production of conception is abnormal, you should be very happy that God aborted it. Okay. And it was an abnormal fetus which got aborted. Very happy. Extremely happy. If the product of conception is normal, and if the karyotyping of the couple is normal, that is when you start thinking that, acha, there could be some immunological problem where a normal product of conception was aborted by the mother. Okay, so that means that there is some immunological cause which has set in. Very important line. If you've heard me for the past 8 minutes, finally comes an investigation which tells you that probably there is an immunological cause. Why? Despite other reports being normal, product of conception being normal, the mother has aborted the child. And when the mother aborts this child for a normal product of conception, please keep in mind you may have some immunological factor, and this is something which you will have to strongly consider. Okay. 3D ultrasound of the pelvis is going to give you an idea of the anatomy of the uterus. Anatomy of the uterus would usually offer corrections. So if the 3D ultrasound has an abnormal anatomy, you should be very happy. And in an abnormal anatomy, there is no immunological thing. You correct the anomaly and the patient will conceive. But if the 3D anatomy is normal, that means everything is normal for the 3D pelvis. That is again a situation where you have to suspect that, acha, this is normal, means there is a possibility that there can be an immunological factor in this lady. All right. And finally, you come to CDC cross matching. When do you actually do this? So before we actually do this, let us look at the role of hysteroscopy. Now, to do a good hysteroscopy, it's very simple. You need to have a meticulous hysteroscopy done. Okay. In a meticulous hysteroscopy, it is important that you rule out a normal appearance. Okay. Or you rule out endometritis. If you have endometritis, then you have to treat the endometritis. And if you treat the endometritis, then the patient will usually conceive, because treatment of endometritis would simply go and normalize the immunology. Okay, it would just normalize the immunology for that patient and the patient will conceive. But when you have a normal appearance, that is when you should think of an innate immunological cause. Okay. So basically, we are trying to look at everything normal and then we are suspecting reproductive immunology. All right. This is one of the most important take home points which probably you can derive from this session, that, okay, when everything is normal, that is when I end up suspecting a reproductive immunology. But remember, the word in hysteroscopy is not hysteroscopy, it is meticulous. That is important because when you do a meticulous hysteroscopy in approximately 75% of the situations, okay, you will find out a cause, especially for endometritis. You can supplement this by doing something called as MUM1 testing, okay, or a CD138 testing. You can supplement that, and that will almost confirm your endometritis. And when you confirm endometritis, you go and treat it. So basically, you don't have to do anything for reproductive immunology. Understanding? Now, finally, when all these reports have turned out to be normal, this is going to happen to you in approximately 55 to 60% of the situations. Most of the reports are normal. Ab kya? When the reports are normal, patient is dancing on your head. Doctor, reports are normal. Give me an answer. This is one thing where you may consider that when all the reports are normal, you may now consider to think of doing something called as a CDC cross match. Okay. CDC cross matching is very simple. You should just know if there is a presence of a blocking antibody in the mother or not, because it is a theory. The theory is based on actually LIT. Okay. So I'll just rub off all these things because this was a good amount of data which patient should be knowing. So your CDC cross matching is something which is going to now tell you that, okay, when I do this, the answer is simple. Either it is negative or it is positive. If it is positive, that means the blocking antibodies in the mother are already present. No need for any therapy, no need for LIT therapy. You move towards empirical therapy. Okay. Empirical therapy includes giving steroids, giving low molecular weight heparin, trying with intralipid, okay, and trying with IVIG. That is empirical therapy. These are some empirical therapies. When the CDC is negative, okay, you will know that blocking antibody is absent. Okay, so in order to form the blocking antibody, you may consider to do something called as PLIT therapy, that is paternal lymphocyte immunization therapy. It will work in approximately 10 to 12% of resistant cases. So that means it will work in approximately 10 to 12% of idiopathic recurrent pregnancy loss cases, because blocking antibody is absent. And remember, along with this therapy, that means along with empirical therapy, if you do paternal lymphocyte immunization therapy, it may benefit in approximately 20% couples. So what happens to the remaining 80% couples? What do we do to these remaining 80% couples? That is going to form the question for treatment, and treatment is something which we are going to discuss in our next masterclass, because this masterclass was to give you this beautiful definition as to how you should investigate and how you should keep in mind as to what you should suspect. Okay. So I'll go back to Zoom and yeah.
Can I ask a few things? Just
Please,
one or
please.
yeah. So, do you do this CME infection? Like, do you do this thing? I mean, do you think it has any role? You told that it doesn't in the torch testing, but
No, this will have a role when a maternal or when a mother is infected in pregnancy with a rash. That is when you do something called as cytomegalovirus IgG, IgM, and avidity and affinity testing. Those are separate things which are for fetal infections. You want to rule out fetal infection during pregnancy. It is not for recurrent pregnancy loss.
okay. And what about doing anti-TPO antibodies? I mean, is that one of the tests that you
It is
consider?
good. Yes, yes. As I said, I missed out on writing 2 or 3 tests because these are my top 10. Remember one thing, any form of autoimmune condition, rheumatoid arthritis, people take HCQS for rheumatoid arthritis. People take, if there are APLA positive people, they will take HCQS. There are so many TPO, anti-TPO antibody positive patients who will take HCQS. Correct? All this is simply basic immunomodulation. Correct? But there is no compulsory rule to do an anti-TPO antibody. When I wrote AMH, definitely we will do TSH and prolactin with that. And anti-TPO antibodies will have a role when there is an abnormal TSH. You may have an altered titer for anti-TPO in a normal TSH also, but then the patient will have a past history of some thyroiditis, thyroid changes here and there. So that is a different evaluation pattern, not in a standard pattern.
Okay. And do you do COVID testing? I mean, is it one of the
We
tests?
stopped. So we stopped doing it. We were doing it till 2022.
Okay. And do you evaluate for endometriosis, adenomyosis in these
That
cases?
is mandatory, madam. See, when you are doing 3D, you can't see. I have seen like this is almost one daily consultation I have, which is a second opinion consultation. Okay, sir, I have been asked to take LIT therapy. I have a 7 by 8 centimeter fibroid on the posterior wall of the uterus. Okay, I mean, it is the heights of nonsense. There are certain grades of nonsense. This is grade 4 nonsense. Understanding? Remove the fibroid. Patient will become pregnant. You don't need any therapy. Understanding? But then these type of things very rampantly happen in our country.
What about ANA? I mean, is it specifically to ask for it?
Best time to evaluate any of these immunological markers is in an interval after pregnancy. Understanding? So that means after 12 weeks of pregnancy, 3 months of pregnancy is the best time. Okay. In pregnancy, quite a lot of these values could be altered. Again, ANA is a marker of autoimmune or rather immune dysfunction. Let's just take it that way. Okay. Or altered immunity. You have it, you can simply treat it. Okay. But you know that that is one of the causes.
Okay, and so this latent autoimmune diabetes in adults that is now coming up because of the autoimmune again.
Yeah.
If you are suspecting a strong autoimmune, say like if their TPO antibodies are high, if they are slightly marginally diabetic with hyperinsulinemia, in such cases, would you want them to take a reproductive immunologist consultation or a immunologist per se, their consultation before you go ahead with your
That
own?
depends if the immunologist is honest enough or not. Because if the immunologist is honest enough, he or she is going to tell you that you don't need an immune therapy in this because you have a known cause. See, remember all these labeled therapies which we have, intralipids, IVIGs, giving empirical prednisolone to the patient, doing paternal lymphocyte immunization therapies. These are considered to be experimental therapies. We can't really label them to be as effective therapies. Okay, because all of them will work in idiopathic recurrent pregnancy loss. They are not going to work in a known cause. You can't really have a 7 centimeter fibroid and say, oh, I did IVIG. No role. Okay, you've done something wrong. You have to accept it.
So what about this hyperinsulinemia in PCOD? Of course, I mean, in your 3D scan, it will be picked up. But do you think this is one of the factors or a spectrum in the
It is
immunology?
it is something which causes poor oocyte quality.
Yeah.
That is the first thing. So because you have that, you need to treat it as a patient who has a poor egg quality. Okay, this poor egg quality is responsible for having a poor endometrium also. As a result of which, in those type of patients, it is better to do an HRT induced embryo transfer. Okay, rather than doing a modified natural cycle embryo transfer, because HRT will take care of all those things which are negative factors, and you are conducting the embryo transfer artificially in those patients. But
What
immunological assistance has no role.
what about these the packages which are now there, like NKSL package, which cost about 5,000 rupees,
Yeah,
and these panels like DICE panel, which you do like with the endometrial sample. Do
yeah.
you routinely do it in your practice where they measure the peripheral NK cell activity or the CD56? You don't do that
No
at all?
one knows what is what. We don't know how much amount of peripheral NK cells to uterine NK cells you need for you to have an excellent immune response. You don't know it. So till we don't know it, it is better to not waste patients' money doing these types of tests. You want to do something, provided you are suspecting endometritis, then it is worthy enough to do probably a MUM1 plasma marker. It is a marker of plasma cell, may be worthy enough of doing that on immunohistochemistry. Okay, we do that routinely, correct? But we don't end up doing these type of things because they have got no role. If I tell you that peripheral NK cells to uterine NK cells, first of all, we can't measure it. But if I tell you that the ratio is altered, then what you will do? Nothing you will
Really?
do. No, nothing you will do because intralipid also may or may not work. In fact, it will be cured by just giving prolonged antibiotics. It is going to be altered in every phase of the menstrual cycle. In secretory phase, the uterine NK cells are going to be higher. In follicular phase, the uterine NK cells are going to be lower. So how do you know? if your timing for doing the blood collection was good for that particular patient sample. We don't really know that, which is why we try to avoid these tests routinely.
Yeah. Yeah, I think that's about it from my end. Anything that you want to add?
No, we'll take one more session on treatments, no, where we'll cover the rest of the points.
Yeah, sure. Thank you so much. It was wonderful.